welcome to Slavery and Its Legacies, a podcast of the Gilder Lehrman Center for the Study of Slavery, Resistance, and Abolition. Slavery and Its Legacies interviews visiting scholars, activists, and others about their contributions to the understanding of slavery, past and present, and its ongoing role in the development of the modern world. Well, hello, everyone. I'm David Blight. I'm the director of the Gilder Lehrman Center for the Study of Slavery, Resistance, and Abolition at Yale. At the GLC, we have been conducting a series we now call COVID-19 Conversations. This is a conversation today with two of my distinguished Yale colleagues on race and medicine. We'll be doing some history and some discussion of our current crisis with the coronavirus, and especially the issues so widely discussed now of racial disparities in health and the history of racial disparities in health. Our two guests are Professor Sascha James-Conterelli. Professor James-Conterelli has her bachelor's degree in nursing from Howard University, her master's in midwifery, and her doctorate in nursing from NYU. She's been a practicing midwife for 17 years. She has done a lot of political advocacy on behalf of midwifery. She runs a clinical practice, and she is a professor of nursing at the Yale School of Nursing. She also served on Governor Andrew Cuomo's commission on maternal mortality and Racial Disparities Task Force. She's also done a great deal of work in the wake of Hurricane Maria back in her home in the Virgin Islands, as well as with Puerto Rico. Sascha, welcome, and thank you for doing this.
Thank you for having me. It's a pleasure to be here today and have this conversation with you both.
And I should have said thank you back, because we've done a panel with you before.
Yes.
And second, my colleague in the history department and FM departments, Carolyn Roberts, who is assistant professor of history, African American studies, and the history of science and medicine here at Yale. She did her BA at Dartmouth, her PhD at Harvard. She is a historian of the slave trade and the history of medicine. She is about to complete her book entitled To Heal and to Harm, Medicine, Knowledge, and Power in the Atlantic Slave Trade. It is especially a study of the British Atlantic slave trade in that book, about which I've conducted an earlier conversation for this GLC series. She uncovers, as no one else ever has, the pharmaceutical and medical labor history of Africans in the British slave trade, both along the famous and infamous slave forts in West Africa and in the Middle Passage crossing to the Americas. That book shows us many things, or will show us many things, but it's ultimately about the origins of the pharmaceutical industry, if you can believe that, and the modernization of medicine in the slave trade and its aftermath itself. So we have a practicing professor of nursing and a professor of the history of medicine and experts on this question of race and medicine. We're going to do some history first. And Carolyn, I'd like you to go first by giving us a sense of some signposts of how to understand this relationship, this in some ways difficult to see sometimes, bewildering, at times maybe even overwhelming sense of legacy of the impact of slave trade and slavery, 250 to 300 years of it, and then through the post-slavery era into the 20th century, from Jim Crow through civil rights, of how this history of disparity has evolved. Help us understand some of these signposts.
Yes. Absolutely. One of the things that we notice with COVID-19 is that it's the result of medical legacies that were hundreds of years in the making. And so to do some of that signposting, we can go to the period that I study and research in the 17th and 18th century in the context of the Atlantic slave trade. We have the first encounter that African people are having with Western medicine is an encounter of violence where clinicians are committing violence upon African people in order to keep them alive and preserve them for sale. When we move into the 19th century and we think about the United States and slavery, there's a long history of painful forced medical experimentation on enslaved people. When we move to the 20th century, we can think about the Tuskegee syphilis experiments, which is now widely understood to be one of the great crimes of medical experimentation committed in the United States. But we can also think about forced sterilization of African American women. We can think about an entire healthcare system across the nation that was segregated, where disparate treatment was built into that very system. And people who are not terribly old today lived through that system. And so if we move into our current century, into the 21st century, we can think about the National Institutes of Medicine, a far-ranging study that they conducted in 2002 called Unequal Treatment. And one of the things that they discovered was that if you have Black people who have the same socioeconomic status as white people and the same level of healthcare, that they will receive poor medical treatment in comparison to white people because there are racial inequities built into the system. And so there's a great deal of medical distrust that African American people have. And in fact, just almost 2 weeks ago now, there've been a couple of studies on whether you would take a vaccine for COVID if one was available. And there were great disparities in terms of race. So white people in one of these studies were 56% of them would take the vaccine, whereas only 25% of African Americans would take the vaccine. And when you think about the fact that African Americans in some cases are twice as likely to die from COVID, but are less than half as likely to take the vaccine, that this long legacy, this long history of distrust is really built on hundreds of years of violence, exploitation, or profound medical neglect. And so the medical distrust that we encounter is logical and a human response to this very troubling history.
So first of all, we've got this enormous legacy of distrust. And I want to, if you wouldn't mind, focus just for a couple of minutes on this, because that distrust comes from first that history of, well, even before the history of racial sciences, there were all kinds of terrible disparities. Disparity is not even the right word for how the enslaved people were treated. But first you've got this era, let's get to America if you want. You get this era governed really by what we've come to call the racial sciences. Then you get into the post-freedom era, and you've got a revival of white supremacy, a virulent revival of white supremacy that comes to another terrible fruition in the eugenics movement. So reflect a little, if you would, on the assumptions, the ideas, the science that this story was rooted in. I know that's difficult to do over 2-3 centuries, but that's where that distrust is placed too. It isn't just distrust in the system, but it's distrust in the very ideas that are used in treating people.
That's right. It is, I think, one of the very troubling aspects of this history is that it has been claimed to be rooted in science.
Yeah.
in scientific knowledge and science we imagine is neutral and objective. And yet throughout this history, we see that that wasn't the case. And so beginning in the 18th century, you see the racialization of the nervous system, meaning that the idea that Black people weren't as sensitive to physical pain as white people. And that remains in our medical system. There was a recent study of medical students who believe that Black people feel less pain and that their skin is thicker. Another idea that is carried over from this era of racial science.
This is current medical students. This is current medical
students. Yeah. And so
go ahead, Sascha. Go ahead.
Please.
I want to add to that what Carolyn is saying, because the system that she is so eloquently describing is a system that is set up to yield the results that we are seeing. It's perfectly designed throughout hundreds of years to yield the results that we are seeing. So we really actually should not be surprised. We start back from the slave trade when Africans were brought to the United States and the manner in which they were sold. Their value was placed for women, for example, since I focus on healthcare and women. The women were looked at as vessels to produce more slaves that were bigger, taller, and stronger. So female attributes such as the size of your breasts and the width of your hips and the roundness of your hips and your bottom were utilized to value the women for whether or not they would be able to reproduce, and their ability to reproduce in the harshest of conditions. So white enslavers were so fascinated by how Africans could reproduce, and even if you remove their food and their clothing, that their children would still survive, even with having these women have a baby and within 12 hours be back in the fields. It was sort of an experimentation of survival of the fittest. Then those that did survive were utilized to reproduce more and more, to create this army or this new generation of new slaves is what they called it, or stronger slave, a stronger generation. And you move forward into, as medicine evolved, utilization of African women for the advancement of medicine, for cesarean sections and the manners in which we birth today, cesarean sections, repairs of lacerations, the use of anesthesia born on the backs of Black women, and surgery being performed on their reproductive organs without anesthesia, and how much they could tolerate, whether or not to intervene. And so we move forward with reproduction and forced sterilization on women, specifically Black and brown women, and the experimentation of family planning methods that we utilize today and we advise patients on. So it's a system that's set up to perfectly yield what we're seeing, the distrust and also the disproportionate effects that we're seeing on such devastating issues in healthcare on the Black and brown community.
So there's always been a corollary development of experimentation on Black bodies, on Black people. And in fact, a recent book by our friend Dinah Barry has shown the scale of the so-called cadaver trade. That is, even after death, Black bodies were still commodities to be sold and used in medical research or experimentation. This is a level and a form of racism that is not yet in the mainstream understanding of the history of racism, let's face it. Maybe out of this crisis, it becomes so. Who knows? Who would predict? but I think stopping just maybe for another moment, if the two of you don't mind, on some of these signposts. I mean, this involved, I think you mentioned, Sascha, forced sterilizations. Carolyn, you brought up the most famous example, the Tuskegee blood experiments, which went on for, what, 50 years? Nearly, or 40 years, I guess, until it was finally revealed and discovered. But it also, there was gene therapy research done on Black people too, right? There's the Henrietta Lacks story, the so-called permanent case, or the eternal uses of her cancer cells. And I mean, and that only got exposed just recently, wasn't it? Or fairly recently.
Fairly recently, yes.
Yeah, yeah. It's an enormous history of this problem of ethics in medicine, or the lack of ethics in medicine. We want to trust medicine. We want to. But with that history, I think it is where you begin to get at your story, Carolyn, of distrust. So we might want to stop on one or more of those signposts for a moment, just to dig it out a little bit to understand it, because there's so many of them.
There's so many. And, you know, I guess one of the places that's helpful to land is this question of medical experimentation, which you mentioned and which Sascha has mentioned. When we think about, in just regular life, we think about the experience of sickness being a place of great vulnerability. Going to a doctor's office and getting into that strange paper robe, all of these kinds of things that for any person,
right,
makes you feel very vulnerable, very exposed. But what happens when you feel sick, you feel vulnerable? And whether you're an enslaved person in the 18th or 19th century, or you're a man in Tuskegee, Alabama with syphilis, trying to get care and treatment, and you're treated as a medical specimen, you're treated as an object, you're dehumanized. The kinds of trials that J. Marion Sims, who is considered the father of gynecology, the kinds of experiments.
He's lost his monument, hasn't he?
That's right, he did. He did. And the kinds of experiments that he was conducting without anesthesia.
Yeah.
All of these surgeries on women's vaginal areas without anesthesia, their screams and pain were so disturbing to his physician assistants that they left.
Yeah.
And the women had to hold one another down because they were enslaved and forced to hold one another down while they endured these medical experiments. And so the level of terror and trauma that has happened, and things like Tuskegee take us more closely into the present, where there was a presidential apology from President Clinton,
right? Because
when you're supposed to be treating these men, you're telling them you're treating them for syphilis, but in effect you're not. You are giving placebos, you're giving vitamins and just water, different sort of vitamin waters, and telling them you're treating them for their disease, but ultimately you're trying to watch how the disease actually kills you.
They were using these men to try to understand the progress of syphilis through their bodies.
That's right.
But they did not take into account the progress, the impact that it would make on the next generation, because these men, since they did not know, even though they knew they had syphilis, they did not know the impact of the disease. So therefore they were reproducing. So therefore they also got more information on the impact of the disease on the next generation. How does it manifest in pregnancy and affect a pregnancy and another generation? So for me, in my field, understanding, to me, what's more important is the measure of a society in general is the health and the well-being of your most vulnerable, meaning your women and children and your elderly.
Right.
And so if your women and children are not being treated well, how can you even say you have a healthy society? And throughout time, as Carolyn is pointing out, we have really done a disservice to the most vulnerable members of our society, the most marginalized. They have been treated as though under the guise of medicine, under the guise of research, however, being treated disproportionately, horribly.
Could I get both of you to reflect a little bit too on the era of segregation, because we also developed in the United States a segregated medical system of necessity, and at least two major Black medical schools, at Howard and at Meharry, and then there were other places. But this becomes a separate and unequal health system as well, with enormous implications. I mean, and positive stories as well as negative, of course. I just read a book called Hattiesburg, terrific book by William Sturkey. It's a history of Hattiesburg, Mississippi, and in some ways, the most heroic figures in that book are two brothers who were a pharmacist and a doctor, both trained. First they went to Alcorn A&M, and then they went to Howard to medical school. There you go. And they end up opening this pharmacy and a doctor's practice for generations. Black folk in Hattiesburg, Mississippi survived through these people. And of course, that pharmacy became a community center. It became everything. On the other hand, the book also shows the desperate situations of disease, especially when the Depression hit in the 1930s. So you get this ironic, two-sided story of this segregated world where people did build healthcare as best they could. But when the New Deal aid came in the 1930s, Black folk weren't allowed to have it, at least in the first New Deal. Second New Deal, a little bit better. But anyway, so the segregated world of health practice still has an enormous legacy, doesn't it?
It absolutely does. One of the things that we notice is that the Jim Crow effects on present day health for the people who lived through that. And some scientists and scholars, they've been noticing that you can be as young as 55 or 60 and have been through that system, that segregated healthcare system, where you weren't able to access appropriate care. You were kept in waiting rooms that might have been in closets or in basements. You weren't able to, sometimes there's some very famous stories where people are dying and they're trying to get to the hospital that will take them, and they end up dying because they can't get into a hospital that will take a Black person. Those things live deeply, not only in the health consequences that people from that era are living with, but they live in the memories of people. The people like my husband, Charles. His father was a doctor, and a lot of people believed that if you were going to go to get a medical care, you couldn't go to a hospital because it would kill you. And so he would go making house calls to individuals. And so this lives in so many different ways in people's lives still today.
Think of the history of heart disease. I mean, the leading killer. And I speak about that as one who just had open heart surgery 3-4 years ago. And I had, a world-class, surgeon do my heart surgery. But if you had heart disease in the 1920s, 30s, 40s, 50s, 60s, whenever, and if you don't have access to a great heart surgeon or just a good cardiology system, I mean, people were dying in droves of heart disease until open heart surgery was finally perfected. But in Black communities, they didn't even have access to that. You know, a major heart surgeon was not something, and nobody had a brother-in-law at the Mayo Clinic, you know, that you could be sent to, right? I mean, this is a world of segregation. The history of Jim Crow is so complex. And I think the health story within Jim Crow is one of the most complex parts of it. Anyway, with enormous implications for what we're experiencing right now. Sascha, speaking of the right now, and there's a lot to talk about, but talk a bit about this world of midwifery, about which you are such an expert, and maternal care, maternal health. Not only in what you've done for so many years, but how it too now has had to confront, women's health has had to confront this current crisis.
Okay, so great, thank you. It's interesting. Carolyn started to speak about that, and in a lot of that, and what I talked about before, of having the value of women, African women, being thought of as through their physical attributes and their ability to bring forth life and sustain life, right? And so we come forward with even the segregation in how Africans and Black people were able to become educated in medicine. So you mentioned Howard University, in which they started a medical school and a nursing school and a teacher's college in order to have Black folks that were educated treat their own Black folks, right? But however, in subpar conditions, with subpar access to education, the educational materials, in order to give them the same education that white folks were getting in medical schools, nursing schools, or in teachers' college. So then you send these Black folks out to treat their own community without access to the same types of medicine and care for their own folks. Come forward to what you're seeing today, which speaks volumes, which has been widely publicized. During COVID-19, you see women in birthing families seeking to not go to the hospital anymore, but have more home births or birth center births because of this distrust of the hospital. What Carolyn talked about, you will go to the hospital and possibly get sick and die. And in the Black and brown communities, that fear is alive and well. So you see more Black and brown women either birthing at home, birthing in a birth center, or even birthing unattended. So as a midwife, I've always been a hospital-based midwife. And my thoughts are, and the reason why I became a midwife was to service the most marginalized members of our community and to the best of my ability. However, when I hear that folks are having births that are unattended at home by themselves because of such fear, it hurts my heart, because I know that having a birth, which is something that we all relish in, it's supposed to be a wonderful time in a family to welcome a new member. Think about it, we all get excited when there's someone in our family that we hear is going to bring forth new life. And we never associate that with the mother dying or the baby dying. We always have hopes and dreams of, is it a boy, is it a girl? Will that be the new president? Will that be a new soccer player? We never associate it with death and dying.
Professor.
Yes, a professor. But for us, in my world, that's a reality that lives in the minds of Black and brown folks. And now with COVID, it's just underscored and amplified.
I'd love to ask Sascha.
It is. Go ahead. Yeah.
Oh, I'm sorry.
Go ahead.
I would love to ask you, Sascha, how do you think that this problem of medical distrust can begin to be solved?
So one of the things that so there's many ways, but one of the things that I think about is, and I went to Howard for a reason, my mother went to Howard. What's been shown in evidence is cultural congruent care decreases some of your disparities. So having access for your Black and brown members of your community to seek education and to seek pathways in the medical field is key. And education, such as at a prestigious university that we sit at Yale, there's a disproportionate amount of diversity in our own community. Breaking down those myths, debunking the myths, improving access to equal education will increase and strengthen our workforce. So then where we're in the community and there's more diversity within your healthcare workforce, within communities, then you start to decrease that level of fear. Because then folks then go and seek care. Because something that Carolyn alluded to is most of us won't even, and Black and brown folks, have such a distrust in the medical system. We'll wait till the very last minute till we cannot take it anymore with pain. We cannot ignore what's going on with our bodies with some Tylenol, Motrin, a tea for some of us, depending on how it is, or a salve, before we go seek medical care. At that point in time, it can be too late for someone that possibly has a tumor, an advanced cardiac disease, or have stroke and die. So we need to have more cultural congruent care, and we need to have the wonderful members of our community, such as Carolyn, such as people, myself, and other members that look like young folks, go into high schools, into elementary schools, and be more present within our communities so that little kids that look like us can say, yo, I can do it too. How did you do that? Can I do that too? Yes, you can. Absolutely.
I suppose it's possible this crisis ends up motivating a lot of young people towards science. Who knows? I'm not predicting that, but it could. Scientists are on TV all the time. They're getting, they're famous, they're important, they're powerful, and they should be. Maybe they should be on even more, as a matter of fact.
I agree. Absolutely.
Instead of somebody else, right? Yeah. I know.
Yes.
Well, to the coronavirus, if you two don't mind being opinionated on this, who isn't? This has been an enormous education for anybody with their eyes open. We've got all these statistics now. Chicago, 71% of its cases were African American. Milwaukee, 70-something%. State of Louisiana, 70% of its cases. Only 30-some% of the population is Blacks. Double that coronavirus cases. Counties, this statistic is astonishing, 52%. Anyway, the counties with the largest Black populations in the United States have 58% of all American cases. I suppose that's enough statistics. We tend to know this. The New York statistics are remarkable in this way, especially from Queens and the Bronx and Brooklyn and so forth. There, it has just utterly revealed this health deficit, but it therefore has us having this wide conversation about socioeconomic disadvantage. Anyone living in a multiple family apartment, people who of course have jobs that are deemed essential, people who work in the subways of New York City or work in bus drivers in all kinds of other cities. All the variety of so-called essential workers tend to be disproportionately Black and brown and immigrant. So here we are with this crisis that reveals all of this. I'm not asking you to predict, what's going to happen with this kind of information and knowledge, but this is not new knowledge. I'm not expert on this like you are, but I've been reading a lot about this. Racial disparities has been discussed, at least in the medical literature, in the sociological literature for decades. There have been federal reports. The Health and Human Services Administration has been putting out reports on this for years, huge reports. And I even read where, was it under the Carter administration in the 80s, they had a report that predicted that they would solve the racial disparity problem by the year 2000. Well, then came the Clinton administration and they declared, no, it was going to be solved by the year 2010. And of course, here we are.
Right.
With the biggest education we've ever had about this problem. What do you think? Is this going to be a paradigmatic moment, or does it always ultimately depend on political turns or political awareness of this at the same time? Let's talk a bit about that, because this is where the public mind is right now. If we're learning all this about racial disparity, all right, what are we going to do?
So
what
can
we do about it?
I want to start a little because I am a New Yorker,
Sure.
actively sitting in my home in New York right now.
Oh,
And I was just on the Governor Cuomo's COVID-19 maternal task force. And it's interesting what you're bringing up, because related to maternity care in New York, especially New York City, there was and all healthcare, but we had to make rapid decisions about healthcare and policies and policy changes. Sometimes within an hour, things would change, and definitely daily. With the biggest impact in the epicenter being New York City, the boroughs that you mentioned. But it unlike all of the other states that you mentioned, I want to focus a little bit on New York and how that really underscores the disparities that we're seeing. New York City, that everybody likes to visit with bright lights and big cities and big buildings we have. In New York City, I worked at NYU on First Avenue. You can walk from NYU on the river and walk up. The next hospital is 3 blocks away, Bellevue. Keep going and you're at Mount Sinai. Keep going, and this is just walking. You're at Beth Israel. So you could walk up First Avenue and essentially hit like 5 hospitals within.
They're all over the east side. They're all over
the east side.
Right.
If you go to places, and now let's talk about the difference between that borough in and of itself, and it's only 5 miles away from Brooklyn, just over a bridge. In Brooklyn, you have 2 hospitals near the downtown area, and then your next closest hospital is way in the middle of Brooklyn without any highway access, which is Brookdale Hospital. You have to drive literally through Brooklyn, multiple stoplights, and we know what the city is like. And then the next one being Maimonides on the other side. And if you go to Queens, similarly widely dispersed because of the more rural, if you want to call it, and within the urban part of the city. And those are the areas because Black and brown folks were offered in the 70s and the 60s the ability to have affordable housing. So they had these homes that were built and they could afford them, but they were put in places where there was lack of access to transportation, lack of access to your social determinants of health, food and green space and hospitals and education. So while Black and brown folks decided they wanted a piece of the American dream of buying a home, they didn't necessarily think, well, I'm buying a home in an area that I don't have access to healthcare, I don't have access to good schools for my children, nor to transportation. Now, looking at that in relation to a pandemic, if you don't have access to public transportation, you don't have access to healthcare, it of course would lead to your increase in the numbers of people that are affected and ultimately demise from a pandemic if there is no access to transportation and to healthcare. And these are people that were of lower income or partially middle income. You're living check to check, or as my mom would lovely call it, robbing Peter to pay Paul, taking money from one bill to pay the next, and hopefully we pay that bill the next month, but we want better for our family, right? In a very, like a 13 square mile radius of boroughs, of 5 boroughs, where you have the largest number of cases of pandemic of over 201 cases of positive COVID-19 patients. So it underscores your disparities, because those folks that are being treated for COVID-19 going to those hospitals, if you really examine the healthcare system, because I know from the COVID-19 task force, these hospitals are mainly the city hospitals. The city hospitals were the last of the hospitals to get your point of care testing. Your city hospitals were the last to get PPE, or personal protective equipment, for your workers that were within the hospitals. Your city hospitals were the last to get extra ventilation. Your city hospitals were the last to even get care when that was being dispersed. So it makes absolutely sense that you would see more of your Black and brown community die in large cities.
Yeah. You can map it. You can map
Yes.
it, and they have mapped it. I've seen these maps, you know, of all the boroughs and where the most cases are. And you don't need to know much about New York to understand why that's happened. Yeah, and it's true now of other cities. Clearly, it's happened in other cities. I mean, I've been reading about cases in many other places of Black folk who've even gone to hospitals, emergency ER rooms, 3 times before they're taken seriously enough to get the test. And in some cases have died from it within 2 weeks or I don't know. Carolyn, what do you think in terms of this? I mean, what Sascha just laid out was a terrific sort of historical, structural explanation of, if you have a pandemic, watch out for your most densely populated people, clearly. And have we even seen the breakouts of this yet to come in certain big cities in other parts of the world, particularly Africa, perhaps? We don't know yet. But how do you see this in historical terms? This is, none of us have ever experienced anything like this. Hopefully we will, but how do you see it?
I think that one thing that Sascha was pointing towards with her excellent overview and really getting into what is happening in these neighborhoods, who has access to healthcare. One of the ways that I think is helpful for sort of broader publics to begin thinking about health disparities is to think about the fact that your zip code is a greater predictor of your life expectancy than your genetic code. Yeah. So where you live has such a huge impact on your ability to flourish. And if with so much attention now on the way that people are living and what is around them, if you have no public transport, what does that mean about your ability to even get healthy food? Because you don't have healthy food to begin with, for example. If we think about New Haven, and we think about what's going on in our neighborhoods here, where a lot of professors and graduate students live in this neighborhood of East Rock, we're sort of targeted to live 10 years longer than the community that lives right around Yale New Haven Health, which is the Hill District. 10 years longer, and we're only a few miles away from one another. So what is going on in the Hill District? There's a site there that I helped start a public health program, so community health, education. And a lot of the people that are coming through, that could come through our doors before the doors were closed, a lot of homeless people, very hungry people, undernourished. There are food deserts right there in that very neighborhood. People that were formerly incarcerated, older people who are really looking for community, younger people, kids who are on various parts of the spectrum at times, who are lonely, who are trying to find ways of connecting. When we held a listening session there to find out what kinds of health topics people were interested in learning about and that we could have community conversations around, they were things like, what do we do about diabetes? How do we eat healthfully? There were kids who said, what are we supposed to do in terms of staying physically healthy if we don't have recess anymore and we don't have gym class anymore? And there were people that were saying, what do we do about the fact that we don't have clothes, we don't have clean water, living in apartments with landlords who have basically created a situation where they can't even make healthy food in their kitchen because it's so dilapidated and falling down. And so the needs are so great and they're right around us. And so I think that one of the benefits of what is happening now is a bright light is being shown in a way that is getting much harder to look away. And so I'm hopeful that maybe it is going to provide the opportunity to begin fixing and creating not just the safety net, that idea of a safety net, which is, I don't know, it's problematic in so many ways because there's so many people that need so much more than a safety net. But a way of really helping to build a more equitable and just society.
So when you ask that question, what do you think of to these people? What do you think of in terms of your health needs? You got answers about basic needs, food, clothing, safety, and so on. Isn't there also a big issue in health disparity question about just how all this racial data is collected? I've been reading about, some states are recording the differences with the coronavirus story, and some states weren't, and now they're picking it up. And so, that there's even a history of that, isn't there? Of how racial statistics themselves have been recorded, which is a huge part of medicine. You take a history, it's the first thing you do. You record, you keep a record. And
you're going down a rabbit hole because now you're going to go deeper into racializing how statistics are even even evolves.
As a good nurse, you would know that, right?
Oh yeah, with gathering information for a basic health history, the assumptions that we as human beings have about folks based on the way they present in a space, and writing that down without even being able to ask another human how do they self-identify is quite fascinating for folks that are in the medical field, and we're supposed to be trained to even understand that. And then for our own government, when we do research, how we even label folks or not are not able to label folks or put them in a box because we can't in our mind fathom who these people are, is just so fascinating. So you now got into a topic that will take us another hour to talk about. Right, Carolyn?
Yes.
Well,
has a lot to say on that.
Sascha, you just volunteered for another podcast then. I didn't know I'd ever do one on racial statistics. It's not exactly the way I do research, but hey, no, it is. There's a big history here too. I know there is. We're kind of running out of time. It's unfortunate. It's unbelievable we're running out of time. But maybe I could get you two to comment on this. This is it's just some more reading I've been doing. And I was reading something about Michelle Obama's Let's Move campaign about obesity and so on. And this is an author who uses a quote from her and then, of course, tries to critique her from the left, which is a habit some academics have. But, she comments about her campaign, which was against obesity. And she was pretty straightforward about it. She said, let's work on this. And this is a quote from First Lady Michelle Obama. And she says it's a lot harder to really feel what those statistics mean, because the truth is that in too many of our communities, childhood obesity has become that kind of slow, quiet, everyday threat that doesn't always appear to warrant the headline urgency of some of our other issues. I found that a slow, quiet, terrible problem, but it doesn't get headlines. I said she was trying to give it headlines, and of course, then trying to construct methods to deal with, including gardening and working out, and so on. Any thoughts on that? I mean, there's been so much discussion here of the question of blaming and so on and so forth, who has diabetes and who doesn't, and so forth. But again, it's an issue that has come up because of the coronavirus, and it's an issue that is not going to go away whenever we finally get through this coronavirus. But I wonder if you had thoughts on that campaign that Michelle Obama ran, which I guess is no longer going on, I suppose.
Well, one of the things that comes to mind when I think about it is the role of obesity in terms of in racial disparities.
Yeah.
Because a lot of people are beginning to see that our relationships with food are, of course, very emotionally driven. And when you're under a great deal of stress, and we know that Black people are living in a state of hypervigilance all the time, because we don't know if the police are going to be called on us when we're out bird watching in Central Park, or whether jogging. Exactly. Yeah. We don't know that, and whether we are going to live or die because of one of these encounters. So the kind of chronic stress that racism causes inside our bodies is coming out in various ways. It makes us more susceptible to chronic diseases like obesity, like diabetes, and these other things, hypertension. I'd love for Sascha to talk about this as well. And so thinking about some of the underlying causes, going deeper than just how much food you're eating or that you're not moving enough, but going below those kinds of things. It's not a matter of finger wagging to say you should eat this or that, although there's a role for that, but to go deeper and say what else is going on in people's lives that is causing this.
So Carolyn brings up an important point, and I think it's something that links us in what we do and why I love having conversations with her, because we link the history and the medicine of it. Because in medicine, we always look for the why. Why is this pathophysiologic thing, or why is a person coming in with a high blood sugar? What is it about you that you have diabetes and hypertension? And so for us, when Carolyn talks about the history, we delve deeper into the why and beyond the basic science, beyond our education that we are taught in school, is to looking at the history and how that's manifesting in the people that we serve at a very basic, a core level. When you look at the years and years and the impact of slavery and racism on the weathering and the cellular changes of Black and brown people, that we also, and the expression and the of our hormones, of our the heightened hormones. One specifically that you're talking about related to diabetes is cortisol. So when your fight or flight syndrome is always enacted, there's a heightened level of cortisol. If Black folks are always in fear when they leave their homes of whether or not we're going to die, will I make it home? When my friend just told me her son on his 18, just went out, and she said, okay, call me if the police stop you. That should not be what a mom has to say to her son when he leaves his house. However, how that manifests at the physiologic basic cellular level of that young man who's only 18 years old, consistently his cells will change because he will always be in fear when he leaves his mother's side and he goes out into the world on his own, will he live or die? How that manifests is the food that he puts in his mouth will not be correctly metabolized in a way that will be nourishing his body. It will actually be keeping him alive. So his body will try to retain, instead of excreting the bad parts of our food, metabolizing the sugar properly, his cells will try to retain that. Thereby he will gain weight, right? If you look at it for the Black and brown community also that have a disproportionate access to healthy food, if all the food that you can eat is high in sugar, high in nitrites, being processed all the time, and we're living in fight or flight, of course we're going to get fatter. Of course we'll be more susceptible because of the weathering to diabetes and hypertension. But how that's being expressed in research is that because of the color of our skin, where we have more diabetes and hypertension, but not the why. There isn't the why. So on the doctoral level, what you learn to do is to pick apart that research and say, but wait a minute, that doesn't answer my question as to why.
Wow, well said, both of you. That's amazing. Well, hey, I'm all for it. This is why we do history. I'm all for it. That's what I do. I want to end on this. I mean, that 18-year-old's great-great-great-great-grandfather, stop anywhere along the way, may have had similar problems. This is a quote, and you can both comment if you like, briefly, because we have run out of time. This is a quote from the head of the NAACP in 1937. Just once again, I found it particularly relevant at this moment with all the police killings and violence and the troubles that we're having yet again. This is Lewis Wright, who was executive head of the NAACP in 1937. He had taken over for James Weldon Johnson. He says, and the NAACP had this health campaign going on. They often did this. There is no use saving the Negro from being lynched or educating for sound citizenship if he is to die prematurely as a result of murderous neglect by America's health agencies solely on the account of his race or color. Now that is stark. That is a brutal comment. But obviously what he's saying is, if we don't deal with health, and you know, and the NAACP had been running an anti-lynching campaign for 2 decades by then, and advocating for voting rights forever. But know what he's saying. If we don't deal with these health issues and the health disparity, the rest of it may not matter. I don't know. Comment? Anybody? I found that a remarkably current sort of comment.
Absolutely. It really brings to the fore the intersection between all of these things. The way that people have to live their lives in a society where they're not only very precarious, their lives are very precarious, but there are so many forces that are contributing to a lack of human flourishing on a fundamental level. And all of these things, as Sascha was saying, are converging in our bodies. And they're responsible for health disparities, for different levels of disease. And yet, when it's covered over with race, so that the explanation is, oh, they're Black, oh, they're Black, they aren't careful, they're lazy, they're not eating properly, they don't bother to get exercise. All of these kinds of moralistic and judgmental arguments, it's so detrimental. It's so detrimental. And thinking about that kind of quote, yes, we're living in a place, in a time where the ability for Black people to get through this disease is severely compromised. Get through this COVID-19 epidemic is severely compromised. But when you think about the various forces right now, we have riots on city streets.
Yeah.
We have COVID-19. We
Yeah.
still have Black maternal mortality. We have a collection of forces that are really detrimental to human life still today. And I think that that quote is very prescient for today.
So that quote oh, sorry.
No, go ahead.
The quote resonates so much with me in my work that I do on maternal mortality and racial disparities, because for me, again, it doesn't matter, especially in New York City, where recently we just turned the corner. So in New York City, in the 5 boroughs, a Black woman with a college education was 12 times more likely to die than a white counterpart with a high school education. And now it's 8 times more likely. Is that even acceptable? That because I pursue education, I'm more likely to die than a white woman with a high school education. So it underscores the fact that if we do not fix our medical field, then we will not address the issues that are really underlying in our society.
Well, yeah, and we've just been suddenly reminded that we have to deal with by recent events, with lynching, voting rights, and health issues all at once, again. Which only goes to show, as we always learn, that history's never over.
Yeah.
My goodness. I want to say this has been a terrific conversation about a terrible subject. And I really appreciate both of you doing this. There couldn't be 2 better people to have on about this together. I think I want to say, let's do this again. Let's just change the subject. So Sascha, thank you so much for taking time to do this. And Carolyn, thank you again for doing this. And I look forward to the next time we can do another podcast. So thank you all for listening. I'm David Blight from Gilder Lehrman Center. And this is one of our COVID-19 conversations. Thank you very much. As always, the Gilder Lehrman Center welcomes contributions from those who support our work and our mission. To give, please go to the link in the event invitation, visit the GLC web page and click on Donate, or email the Gilder Lehrman Center for more information. The Gilder Lehrman Center is conducting a widespread fundraising campaign to sustain all of the activities we do in the coming years, and we welcome any help you can give us. Thank you very much.